Welcome to The Pursuit of Health, the podcast on health policy for a free and modern society. Welcome, everyone, to another episode of The Pursuit of Health. Joining us back on the show is Tina Marsh Dalton. Welcome back to the show, Tina.
Thanks very much.
So we recently had Jessica Dobrinsky on to discuss drug pricing and PBMs, but that mostly focused on the politics and policy of PBMs and where that is right now. The reason I wanted to have you on again, Tina, is to discuss the economics of drug pricing and PBMs.
Just as uncomplicated as the politics.
That's right. And yeah, just to kind of dream of like what actual alternatives we can come up with. And I would definitely recommend our audience to check out your Substack series on this called Disentangling Drug Prices. And I think a very sensible place to start is this kind of analogy that you have to the layering cake of drug pricing, which is like a layer cake, but not delicious. So
Yeah, not delicious.
let's just get into understanding the economics of drug pricing in America.
Yeah, so there's so many layers, and like I said, they're not delicious. A lot of people are confused, why are drug prices so like, why are they all over the place? And um I call my writing words to the wise, right? So I'll explain why. There might not be great reasons. I'm just going to explain what's happening, and the punchline might not be like, and this all makes sense. But I like to set it up thinking about, especially drugs, they're just a consumer good. And if we think about other consumer goods in our everyday life, we could think, how do they get from the place they're produced to us consuming them? And my favorite example is always an apple, because I grew up in apple country, I guess, and everyone knows what an apple is, right? So you think about, you want to consume an apple, how do you get it? Well, there's the farmer. And if you're really cool, right, then you go to the farmer's market and you're even consuming directly from the farmer. But, if you're doing it the rest of the year, or you don't have that much time, there's maybe the apple farmer, and they send it to a distributor, and they send it to a grocery store and to you. But the whole time, so now we've got 4 different players in here. But one thing that's important here is that the farmer, the the payments are going to go always in a unilateral direction. So if the farmer gives apples to the distributor, they're going to pay for the apples. Then it goes to the grocery store. They're going to pay for the apples. And then the hungry consumer is going to pay. So the dollar signs are always going in the same direction. When you receive an apple, you send the payment. And it's like the classic, if you took intro econ and you had like this flow of payments diagram, right? Like you give the good and then the payment goes to you. Okay. So pretty simple. Maybe there's 4 people involved if we're being really, really complicated. If, we could even skip the distributor sometimes. Like some of my favorite grocery stores, right? They put a little sign. They're like, this came from blah, blah, blah orchard. All right. The pharmaceutical supply chain is not as simple as this. So in my writing, I have an example that the American Diabetes Association put up. It's just a lovely picture, but they already have 6 different players in the game, because they have the consumer and then they have the manufacturer. But in between, there'll be the wholesaler. But that is not who you usually buy your drugs from, right? I'm just buying one package of pills. So there will be the pharmacy. Maybe the pharmacy buys it from the wholesaler. Oh, maybe your insurance plan buys it. And then it turns out this is all very complicated for the insurance plan to deal with. So then we're going to have these things we alluded to called PBMs, the pharmacy benefit managers. And before, like, without even trying to go into, already we've gotten 6 different players. And every time we have a player, right, I talk about the layer cake now. The layer is, if you're going to operate your business, you need to make a margin. You need to have some profit from operating your business. And even if you had 0, right, like you got to pay for the workers, you got to pay for the administration. Like if you exist as a link in this chain, you're going to add some costs onto the final product. So we've got already 6 different layers here. We've got a lot of different costs being added in. And then what is really like mind-blowing about this supply chain for pharmaceutical that is really different from our traditional consumer goods is that when I talked about you give the good, you give the apple, you get back payment. Then that apple keeps going down the chain and the payment comes the other direction. The difference with drugs is that the drug goes to the next layer and the payment comes back, but sometimes payments come from all other locations in the chain. So it's no longer really a chain. It's like a complex web. If you look at this picture on my page, it's just a web of all kinds of links. So sometimes there's the cost of the product, but there's these things called rebates, which the pharmacy benefit managers have introduced into the landscape. And rebates are invisible to the consumer, but they're making it cheaper for the insurance company to push you towards certain drugs. They might also make it cheaper for the pharmacy to be filling certain things. And so there's all these hidden back and forth payments that are happening that consumers don't know anything about, except for when we show up at the pharmacy and pharmacy A has it for one price and pharmacy B has it for another price. And we're just confused. Why did this end up different? Well, it's because there's a very complex web of payments going both directions behind us. So first, I usually just give the big overview because it's just to
Right.
maybe to set up the audience with like, if you find this opaque and confusing, like you are right. Like don't feel like you're missing something, that there's a simple chain that you just can't figure out. No, it is a very painful web of payments all going the wrong direction.
And what's interesting about that is that, I mean, people really love to like beat down on PBMs, but then they are still attached to this idea that, well, insurance should cover my prescription drugs, but it's like you wanting to have it covered leads to all these complexities, which kind of necessitates some kind of middleman having to navigate it. And so we'll get more into kind of how to resolve that conflict later on. But other people, when they look at this complexity, approach it a slightly different way. They'll think like, we just need to put a different sticker price on these drugs, or we need to kind of
Mm.
um, tie down the PBMs in terms of what they can and can't do. Could you explain those kinds of solutions and what you think about them?
Yeah. So I'll first talk about, because one thing I want to say about PBMs is like, why do they exist? Because like in my class sometimes when I'm teaching these things, and I have students with parents who are often in the medical profession, right? So I like to start some units like, we are just going to talk about the incentives that are set up. I believe the people in the medical profession are trying to help the world, right? They didn't come in and they're like, I have a devious evil plan of how we can raise all healthcare expenses and make everything inaccessible. Okay, that maybe wasn't how we started. So what was the good intentions with PBMs? Well, when you think about, we want to have drugs covered under insurance because in the US we think, oh, it's healthcare, it should be in our insurance. And certainly some drugs are very expensive. So there are tiers of drugs. If you end up with needing chemotherapy, those are very expensive drugs. You didn't know you were going to need those. That's going to break the bank. So we want some drugs covered under our insurance plan under traditional ideas of insurance. Um, but when you think about what the insurance plan is normally negotiating, it's a very local product, actually. I'm not going to go to see my primary care physician in another state, right? I'm going to, even in with my own town, I'm not even going to go, I live in Winston-Salem. I'm not going to go to Greensboro. It's only 40 minutes away, but I'm just going to stay here. So the health insurer is negotiating very locally for most of its services. It's going to be with the local hospital, local health system, local providers, and then suddenly we've thrown in drugs. And drugs, of course, are not produced locally. I don't know really if we have any here in Winston-Salem. I'm pretty sure we don't. We did have a PBM for a while. Um, but they're produced nationally or maybe even internationally, right? We're sourcing our generics from other countries. So that sets up a funny problem for the health insurer because they've specialized in being really close local negotiations. Suddenly
Mm.
they have to do this totally different set of negotiations. So having these pharmacy benefit managers come in, they can just take over the negotiations at the national level, especially when you think about the relative bargaining power. A big consolidated insurer has a lot of advantage over your local hospital. They don't have the same advantages over Pfizer, right? Because Pfizer's much bigger. There's only one of them. So if we're trying to match firepower to firepower, right? Several health insurance plans are all going to contract with the same pharmacy benefit manager. Now they're a big guy because they got all these different health plans that they're covering, and they're going to have better bargaining power with Pfizer, was the idea. That they can sort of peel off this part from health insurance negotiation that is not local, and they can do it at a national level. That was the idea. As we go throughout the health system, it's been getting very consolidated. So I talked about the health insurers. They actually have a lot of negotiating power in the local market because they've gotten so big. And then the local market has decided to react to that by consolidating as well. So that instead of individual privately owned hospitals, they're now part of giant health systems so that they can negotiate better. So everything's getting consolidated. So if you look at all these prices and I'll throw people a bone if they just are like, "This is a mess. Let's just slap a sticker on it and be like, all of these prices are all over the place. They're all too high. Like, just put a low price on it. Like, just put a sticker, print out stickers that are a low number, and like stick it on everything." And I like to call this like the "there I fixed it" plan. If the idea that we should have price controls, and this was in the Inflation Reduction Act, I think, in the Biden administration. And they were like, insulin is too expensive. Huh. What should we do? I know, let's just make it illegal to be expensive, right? Like, there, I fixed it, right? I mean, they like tie a little bow on it and they're like, I fixed it, right? But I don't think these websites exist as much anymore, but I always think of this as the "there I fixed it" plan because there used to be these memes that would be like, the bumper would be falling off a car, and people would take duct tape and,
Okay.
like, tape it on, and then they would label it, "There, I fixed it." Like, problem solved. And I feel I want people to view price controls as the same problem, right? If your bumper is falling off your car, there's a bigger problem you need to address, right? You might even need to replace the bumper. You need to like do some serious work, and just putting duct tape on it is not really a permanent solution. It's not elegant and it's not effective. And so price controls are a lot the same thing. Why are these prices all over the place? Well, it has to do with these rebates that are flying back and forth in the wrong direction, flying upstream. Has to do with how many layers there are, and a lot of it has to do with consolidation in the producer market. So if we think, gosh, insulin prices are too expensive, what do we do? Well, we got to think about why they're expensive. If we just slap a low price on it, we did nothing to deal with the fact there are only 3 producers of insulin in the United States. Which, if you don't know much about the history of insulin, this is actually kind of insane. Insulin has been generic for 100 years. What? Like, why do we
Right.
have monopoly power in insulin? And so the insulin story goes off on a track of, well, it's all covered under insurance, and it's linked up in a sort of printer cartridge printer sort of way where there's amazing new technology in insulin, the pumps that they're using. But then the manufacturers say, well, you need to use my brand of insulin with my brand new delivery system. And so we're still stuck in this non-generic world where we only have a few producers. And so just saying the price should be cheap, we haven't fixed the underlying problem. And so maybe I'm just a whiny economist, like, oh, she just, like, but the fact is we made the price cheap. Like, stop being all worked up about the details. Like, the price is cheap. But the price is cheap. We didn't fix the underlying problem. We didn't fix the fact supply and demand are linked up in some other way. Um, so I'll give examples that maybe hit closer to home than price. So we can make things cheaper, but anytime we take away prices the way that people buy and sell, because we've essentially taken it away, price would have been something different and we put this cheap sticker on it. It's always going to be allocated in some other way. By allocated, I mean it's the people wanting it and the amount to go around did not change. So I like to work through insulin because I have personal stories about it because my mom's a type 1 diabetic. So what happened around the time that insulin was getting short, if we make it a low price, there are lots of people that want it, and there's not enough to go around. The producers don't have any incentive to make any more, right? Because they're not going to be able to charge more for it. And what happens is now you can't find it. So my
Mhm.
mom was at like the end of a month. My mom's had it for 40 years, right? There's no uncertainty to her needing it. She knew she needed it. And she couldn't get it because it was thrown into insurance, and she had asked for approval, and they couldn't find a supply for her, and blah blah blah. And at some point, she was getting frustrated. She was calling, and someone was joking with her. They're like, "Well, you could just eat a candy bar and sit in the ER, and once you keel over, they'll give you some." She's like, "I'm gonna have to try this," because she's down to like a couple days supply. So yeah, we stuck a cheap price on it, but we when we take away price as the way of allocating, it means it's going to be allocated by other ways. And in my mom's case, it was by time. It would have been by connections. Like, did she know someone or did she have to go to the ER to get herself a nice supply because she was almost out? So just saying the price is low doesn't change the fact of the number of goods there are. And we haven't changed the underlying problem of a monopoly market. So we're going to do is be making it difficult for some people. Maybe you're lucky enough to get it. Okay, then you're well off, but then there's a segment of people that didn't, and we haven't actually fixed our problem. We've maybe made it worse. The other thing I like to say about price controls is, so I don't know if I've mentioned before on the podcast the Tina Marsh Dalton um, standard for policy evaluation. The Tina Marsh Dalton standard is your policy should not do the opposite of what you intended it to do. Like, this is the minimum bar, right? So like, oh, we want to make insulin really accessible. Let's make it cheap. Well, you just made no incentive to make it, and you made it hard to allocate to the people who need it most. So you kind of made it hard to get rather than easier to get.
Right. So if something like price controls is like the duct tape, I fixed it
Yeah.
approach to uh, not just drug prices, but kind of like not really dealing with the complexity that rose for the need for PBMs. Let's
Mm.
dream a little. Like without political constraints, what could actually move things in a better direction that does fix the underlying problems.
Yeah. So there were a couple exciting I call them headline grabbers. Mark Cuban of Shark Tank was trying to make some big waves because he was experimenting rather than trying to put a pharmacy benefit manager in between as an extra layer in all these things. Uh, he was trying to negotiate more directly. So he wanted to pull out the PBM and just have the wholesaler uh, that you could buy directly from the wholesaler. And he was going to be like extreme about this and have a promise of the profit margin they were going to stick to. But at any point we're going to delete one of the players in a I don't want to call it a chain because now it's no longer linked all together. Any of the players in the web, right? You're going to take out one of these layers of frosting of profit margin and you're going to make it cheaper. So this seemed promising. The other player in that game was Amazon. When you think drugs are a national product, drugs you consume on a schedule. You know what Amazon is awesome at? Getting stuff to people across the nation on a schedule, right? So they were also trying to experiment by cutting out the middleman and trying to go directly. What happened, and maybe you covered this a little in your politics, was that the existing entrenched pharmaceutical benefit managers didn't like this, right? They're cutting into their market share, and they actually were able to negotiate contracts that made it illegal or like, that prevented the people that signed the contract from contracting with Mark Cuban's Cost Plus. And so they essentially had to end up partnering with a PBM. Like, if you can't beat them, join them, because they were closed out of the market through these pretty uncompetitive practices by the PBMs. So these are good ideas, but maybe we can talk about the much better world, or the marginal, if people follow the idea of marginal in economics and just small improvements leading to a better world. uh, what I want Americans to think a lot about, and I want to start thinking about it. Maybe if they hear this, the first step is just don't get scared by it. The idea that what should our insurance plans be for? So what I just talked about, my mom and insulin, she's had it 40 years. She knows how much she needs. Actually, often she knows better than the nurses, right? Like, the nurses have not been alive as long as she's had the disease. And she's like, listen, honey. Um, so it's very predictable. She knows what she needs. This could be a generic product if we could get the market to cooperate. Um, there's no uncertainty in it. What insurance should be, it should be safety for all these things that are uncertain in our life. Like, healthcare is full of uncertain things. I could get hit by a car. I could get cancer. If these things happen, it's going to wipe me out. I hope they won't. And actually, there's a pretty good chance they won't. But if they did, it would wipe me out financially. This is what insurance was designed for. Now, insulin doesn't really follow any of those requirements, that it's uncertain And it doesn't have to be expensive. Right now, when I'm saying it, it might sound kind of crazy because you think, but it is expensive. But we went through. Why is it expensive? It's expensive because there's monopolies providing it. It's not necessarily expensive because it has to be expensive. Um, what are the drugs in our world that wouldn't necessarily need to be in insurance? Why would it be great to take them out of insurance? So, to think about what would the world look like if we could take them out of insurance? If we just did it tomorrow, I could understand people would be like, that sounds insane. Everything would be expensive. I agree. It's because we have not fixed some fundamental problems. But let's think about what is the class of drugs where this could come out pretty easily. So, giving an example of thinking about the world of over the counter drugs, right? This is different. You don't need a prescription for them, but let's just think about what are their qualities. So, there are several of those drugs that maybe they're unpredictable. Like you don't know if you need cough syrup, but also it's not expensive. So like, you know, those are fine. Let's not worry about those in insurance. They might be uncertain, but they're not expensive. So don't put those in. The other piece is drugs that maybe there is some predictability to it, right? Like seasonal allergies, they happen, unfortunately, every season, right? You can predict them. Different chronic disease drugs like hypertension drugs or cholesterol drugs. You get them, and now just keep taking them every single day, right? You can pre-order just like your toilet paper from Amazon. These kind of drugs don't belong in insurance. What could they look like if we weren't there? Well, if you need aspirin, which maybe is unpredictable even, you don't know when you'll get the headache, you just know you'll probably need it. You can get it from whatever pharmacy you want. You can shop for it. You could get it online. You could get it locally. You you don't have to ask your insurer for permission first, right? Part of the holdup for my mom was she had to like get an official sign off from somebody saying she
Right.
needed insulin after 40 years. Like this is
Wow.
absurd. And what was happening sometimes is like the paperwork got held up somewhere, right? So she's sitting there waiting for paperwork to prove that she has had diabetes for 40 years. And in the meantime, she's running low on her supply. All of these over-the-counter drugs, you can shop for them easily. You can price compare. You could order ahead. When my mom tries to get insulin ordered to, like she's on vacation visiting my sister, visiting her grandchildren, she can't have it mailed there because
Yeah.
the insurer won't let it be mailed there. But what if you could just run to the pharmacy nearby and pick it up? Over-the-counter drugs, we have price shopability. We have easy availability. We can plan ahead. And we also have the fact everyone can get it. So what we have in the US, we have not solved the insurance problem. That's a big problem, right? How are we going to get that 8% of the US that does not have any insurance at all? How are we going to get them insurance? That's a big question. But in the meantime, they have perfect access to aspirin. They have perfect access to Robitussin, and they can price shop for it. So yeah, trying to get all 8% of them full insurance, that's big. But let's think about what we can do today. We could pull all of these chronic disease drugs. We could pull out drugs that have a predictable component. We could pull things like medical devices, like a CPAP machine for sleep apnea. You sleep every night, like you know if you need it, right? We could pull these out. If we pull them out into the market, we would, and I'm not saying we should pull them out and take away any prescription, right? We can still have prescriptions. We can still have the same quality monitoring. All we're doing is we're changing the way that we pay for it because that's all insurance does for
Right.
us. Insurance is not healthcare, sadly. It is just a way to pay for healthcare. So what I'm saying is we need to be thinking about what are these items that we've thrown into the big old mess of health insurance, pull them out and make it easy to shop for good prices, make there to be better availability. If you think about like allergy medicines or cough medicines, another advantage is that they are tailored to the consumer, right? Do you not like swallowing pills? Look, here's a liquid. Do you want it in grape flavor so your kid will actually drink it? Okay, here's a grape flavor, right? There's a lot of variety, so it can depend on the consumer's preferences. And variety also means there could be variety in price. And we're talking about how can we make healthcare accessible to everyone, right? I think when people hear let's take it out of insurance, they think, but what about the poor people? How will they afford we have to give them more coverage. But if we pull it out of insurance, we make it price shoppable, we introduce competition to bring the prices down, we've given them access that no one can take away. We've given them access that if they decide to change jobs isn't gone. We've given them access that if the state budget is running low, they aren't suddenly ripped out of some kind of coverage, right? They can go to the local drugstore, shop for the best price, buy it ahead of time when it's on sale. And this is something they have more actually certainty and regularity by doing something like that.
So it seems to me that the economic case for pulling a lot of prescription drugs, except for the very expensive ones like cancer drugs, out of
Mhm.
insurance to the benefit to patients. It might be difficult to persuade them of that, but the the case is pretty clear to me. But what's the case on the other side, like for insurers? Like you might even think insurers might be happy not to cover prescription drugs because it's like less things for them to cover. But might there actually be an economic case why they do want to cover it, or like why they want to maintain the web?
True. So I think there's a lot of advantages for insurers because it streamlines their model if they don't have to deal with it, and they they don't have to pay for it. I think the yes but in this conversation is, well, if I'm not covering heart disease medications free of charge, right? Then how do I know that they're going to take them, right? And if this is
Mhm.
a lot of preventive medicine,
Right.
how can we make sure that people could cover it? So this is an interesting question. There's some level of when things are free, people don't value them as much. This is what we see from behavioral economics. So moving it away from free doesn't necessarily give me a reason to pause, because free and some small copayment, we actually see better compliance with some small copayment. People have some skin in the game. Um, the question would be where the balance would fall. So if we make it more expensive, we know from basic demand lines, right? Less people would consume it if it's more expensive. At the same time, a lot of the things I just described in that story are inconvenience and time and
Mhm.
bureaucracy.
Right.
So there would be a balance between these. If I have to go through my doctor, or if I have to apply to the insurance company, or if I have to read the documents, maybe I just give up. Um, if prices are more transparent and I can just run to any pharmacy I want, I'd probably there's probably some world where I also am more compliant because I got rid of a lot of the non-monetary barriers.
So might there be then a case for certain businesses to step into this area because there's actually like a business model here. I mean, we've seen this with Mark Cuban, but
Mhm.
just in general, that they would still be a middleman of some kind, but their benefit would be not only cutting out a whole bunch of other middlemen, but
Mhm.
offering things like convenience and transparency and um, just a better shopping experience. Do you see that taking off and like maybe being the way that we slowly start peeling um, routine prescription drugs out of the insurance machine?
Yeah, I'm talking about this, like it could be some future wonderful world, but there are already pieces I've noticed, and it might be awareness is pretty low right now, but for and I think they speak to the fact that the bureaucratic and time costs of all this are just annoying and opaque. So I
Mm,
know Walmart had published, it might even be like 10 years ago now. They had a $5 prescription list, and they just had a list of like 40 different drugs, and they said, "These are $5.
mm.
Come Come with your prescription. We don't need your insurance. They're $5, right?" And this is very attractive. It's very clear. You know exactly where you're gonna go. You're already at Walmart anyway for some other needs. That's really straightforward. The other one I talk about a little bit in my article is GoodRx, which, I think when I was writing this, I often write my pieces based on whatever sickness my kid got. And so I think we had to get some, ear infection medicine or something. And GoodRx sometimes advertises places, but it's hard to know because the consumer doesn't know if you can trust these or not. So that if you just see an advertisement at the ER or something, you're not sure you want to pick this up. But it's basically like a price comparison tool. So I could put in my zip code and the prescription that I needed, and it gave me for 4 or 5 different pharmacies in my area what would be the price in each of these pharmacies. Um, all of this is cutting out the middleman. Well, it's sort of like you're getting a personal shopper that's smarter than you in this whole complex web. I think it's still small at this point, right? The awareness of these kinds of services is low. Um, for me, trying to check the website, I checked the website after I bought the prescription, right? Like, it was more like part of researching the article. Um, it's easier if just over time you can notice prices. Like I know, so my mother-in-law is always checking out the prices, right? So rather than having to go to a website, the more that it's worked into the just your daily life, like aspirin, like trying to get your regular over-the-counter goods.
Right.
This would be a I could see this the benefits would multiply by much more than just a website. I could see the websites working better for these small, sort of regular purchases, but that you maybe invest some time in. So I'm thinking about the CPAP machines. That's the kind of thing you have to order, and you sit down once and you compare across several manufacturers. I know right now there are some CPAP manufacturers that are functioning just without insurance. What would make this better, so to encourage the social transformation is when we only have half the people in the market buying from the non-insurance route and then half the people in the market buying from the insurance route. One thing we didn't cover yet is, well, insurance is annoying to work through. It's bureaucratic, it requires time, it restricts your choice.
Hmm.
One thing I find, I want whether I could get some people on board that wouldn't think they were on board, right? People that care about having rights over their birth control.
Mm.
Why are we handing it to the insurer to make the decision, right? This is a predictable event. And yet it's the insurer that's deciding what you're covered for. I think a lot of people could get on board on that level. I'd like choice over what I consume rather than, well, this employer plan covers it and this one doesn't, so that determines what goes in my lifestyle. But the other piece that insurance layers on, besides time, bureaucracy, and limiting your choice, is it inflates price. Because when consumers are consuming through insurance, they're only paying a portion of it. And this is what we want when it's some huge expensive thing like cancer that we did not expect. But when it's some predictable event and half the market is only paying 20%, well, if I was a manufacturer, what would I do to my price? Well, I know I can raise it by at least 80%, right? Because they're not paying the rest of it. So if we've got half the market consuming through insurance and half the market not, we're really losing out on a lot of the price drop benefit because half the market is now price insensitive because they're only paying 20% of their price. And so the drop in price for those who are paying out of pocket is really hurt because the prices are being artificially inflated by the other part of the market that's consuming through the system we don't need to be consuming through.
So, I mean, if we really want to create like a kind of a, I don't know, a social movement of people shouting, "Take prescription
Take it
drugs out,
out!
take it out of my insurance," right?
Yeah.
Um, it it seems that from the consumer side, the, for the time being, that's going to be a pretty small number because that's going to be people who are just so fed up and so frustrated with
Mm.
dealing with their insurance, and or just like can't afford to copay and things like that. So then they'll go to Mark Cuban's cost plus drugs
Mhm.
pharmacy model and other things like that. But isn't another component of this the fact that a lot of consumers are kind of passive by design
Mm.
because employers very often are the buyers of the insurance. So, like, do you see any role for them in also getting fed up and like making better choices on behalf of their employees?
Yeah. So the employers might have the same advantage of the insurer in that if they're covering less, then they're paying less. Um, we do have the structural problem in the US that employer-sponsored insurance is tax exempt. So if they want to give me a raise, they can give me $1 and I have, well, only 70 cents to spend on my Corvette, right? Like they're going to take 30 cents for taxes and the rest is left over. But if they pay me $1 in health insurance benefits, I, as the consumer, get the full dollar. And so
Right.
we've basically made healthcare on sale in the US. And when something's on sale, you're going to bulk consume it. Uh, the problem with trying what you were just describing of how could they benefit and how could we pull it out, it's somewhat of an equilibrium problem.
Mm,
If one employer pulls it out, then those employees just feel cheated. They haven't gotten the benefits of everyone flooding the market. It's only them sitting there lonely chirping. Um, I was describing it like if you're walking down the street, right, we've boarded up all the stores by putting them in insurance and the prices are too high. And if we just throw some people out on the street and say, "Go shop," right?
yeah,
The
good luck.
the doors are closed and the prices are too high. So it has to be something that would be coordinated to get a critical mass of consumers out into a market looking for their CPAP machine.
Mm,
Um, I think some of the critical mass might already be there in the generic chronic disease drugs.
right.
I think the barriers to searching are already so annoying. And then Walmart is there, Amazon is there. They're trying to get direct to consumer mailing of the pharmaceutical drugs. There, I think we're a lot closer because there are enough people that it just sort of seems annoying to deal with the insurance, and they'll just direct purchase. I think pharmacies help sometimes if anyone's ever been to a pharmacy and the pharmacy tech, like, does some checking for you and says, "This would be easier if you just paid out of pocket." So, we have some helpful nudgers along the way.
So, I mean, I thought that we were gonna have to think of this dream as something that was gonna be like this faraway thing in the future that was gonna take forever to get to. But what you've described is like these very concrete steps where we can focus on this specific class of drugs like generics and under these conditions. And that makes it sound a lot more doable. And in some ways, it's already kind of happening.
Yeah, I think in that pharmaceutical drugs is already kinda happening. Um, I w I'm trying to think of, like, ways forward now that you're prodding, and one advantage or, like, a silver lining to the health insurance exchange subsidies ending. Right?
Mm,
So the big government shutdown was about extending these subsidies and they were not extended, which means that the prices went up for probably at least half of the folks on the exchange because we were subsidizing about 90% of the exchange, which that's already, I mean, it's a fiscal problem, but it's like it's a wake up, right? Our prices are too high if 90% of the consumers need to be subsidized by
yeah,
the federal
yeah,
government. And so new people are being thrown into plans that require a lot more out of pocket costs. So this is unfortunate for them. I'm not saying this is good, but it might be a moment where we have a lot of consumers looking for cheaper avenues. So I'm
right,
putting a call out to all the innovators to get your price information to these people that are now much more interested in
right.
prices in healthcare than ever before. I'll leave people with just another counterfactual because I think the hardest part about this idea is thinking about the landscape that exists today is expensive and obtuse. And what do you mean you're going to just throw me to the wolves and take it out of insurance? But so I'll give the example of sort of a simpler, less medically needy, but certainly very predictable need. I like to talk about glasses.
Mm,
So I don't, if people are just listening, they don't know that I'm wearing glasses, but like you probably guessed it already, right? Like by my personality. Of course I've needed glasses since I was 10. Um, so very predictable, very shoppable, should not be expensive. They are expensive because there are a lot of monopolies. There is a couple key monopolies. It's one of these fascinating, you didn't know that this was a monopoly, stories, but they're just pieces of plastic, right? And we know how to make plastic cheap. Um, but by putting them insurance, we've added several things. My first story is about my daughter's kindergarten class. There was a little boy in there that had glasses, and I saw the parents, and I was like, "Oh man, I'm so sorry. Like, that's so expensive, and he's totally gonna break them after a week wearing them." Or like, "What do you
mm,
do?" And he was like, "Oh, I use Zenni Optical, and this is not a sponsored like, they have to sponsor me at some point, but it's just this online retailer, and their glasses were, like, $35. They're not as nice, so I'm actually wearing a pair right now, and I bet you thought they were fashionable the whole time. The lenses are a little thicker according to my optometrist. But the thing is, you can give it to your kindergarten kid, and he actually had, like, glow in the dark ones, which is so cool.
That is cool.
And think of, like, the access issue there, right? He can have them. Maybe if they were a poorer family, they'd be like, We're just gonna wait till he's not gonna break them." He can have them in glow in the dark, so now they're, like, cool and he wants to wear them. That is amazing access. I actually got sunglasses, which I'd never gotten before because they're always too expensive. So making things a little less quality even, but cheaper increases access exponentially. Um, and so thinking about a world where you could shop, and if you wanna buy expensive glasses, you still can. Like, you can still go buy those $500 pair of glasses. No one is stopping you. But if you want to give them to your kindergartner, it's now available, and they are quite functional, and he is doing well in school, right? Because he can see and he can read and all of that.
That's interesting because I think people, when it comes to healthcare, quality has like almost like a different element in their mind where, well, if it's my health, well, then like it's not even about it being like the best quality, but you can't skimp on quality whatsoever with the
Mm.
implication that if something is like below like the highest quality, it's like it shouldn't even be in healthcare. But
Mhm,
that's not
mhm.
true at all. There are things that could be quote unquote lower quality, but they're perfect for your needs. And
Yeah.
so I think people should also begin to recognize that, but I think it's kind of like a cognitive barrier that people have.
Yeah, I think thinking of quality as only one dimension is makes people misunderstand the benefits that you could have, right? So if quality is like and glasses is like the style and the thinness of the glasses and the accuracy of the prescription, actually maybe just accuracy of the prescription is the only part that I really care about. Otherwise, I have zero access, right? If it's the question of nothing or, the same kind of glasses that does Elon Musk wear glasses? I don't know. Like billionaire glasses are maybe not necessary for this kindergartner if he will actually wear them, and he'll have an extra pair when he breaks it. So thinking of quality as a multidimensional part of the good and which dimensions actually matter for your purposes.
So yeah, here's to hoping that people can start thinking about prescription drugs more like prescription eyeglasses, and hope that'll not only make drugs more affordable, but also much more convenient and maintains a variety of quality. And I think we'll leave it at that for now. And I'd like to thank Tina for coming on. I'd like to thank our audience. And till next
Oh,
time.
thank you so much for having me.
To stay up to date, subscribe to our show from whatever podcast platform you are listening from. To support our show and the Center for Modern Health, you can make a tax-deductible donation at centerformodernhealth.org/support. Thank you for listening.